Hi, and welcome to RadOnc Talks, a lecture series designed for students and residents of radiation oncology. My name is Ria. I am currently a PGY5 resident at the University of Pittsburgh, and today I'm very excited and nervous to launch into a brand new series on head and neck cancer, starting with a discussion of head and neck cancer anatomy. I'm excited because I think it's definitely a very interesting disease site, and it's also a very popularly requested topic. Many of you have actually reached out and asked me to cover head and neck on RadOnc Talks, so I'm definitely excited. I'm also nervous because I do think that head and neck is a very daunting topic, and starting a brand new series on head and neck cancer kind of feels like standing at the bottom of a very tall mountain. So I'm hopeful that I can do it justice. One of the reasons I think that head and neck is actually very daunting as a disease site is because of the anatomy. And there's so many different subsites within head and neck that all have kind of subtle nuances and differences in terms of how they are actually managed. And so my goal in this introductory kind of lecture to head and neck in general is to just very simply go through the anatomy of the head and neck and kind of one by one go through the different disease sites that are covered within head and neck cancers, and then also go through the anatomy of the lymph node levels of the head and neck. And my hope is by the end of this talk, we will have covered all of the different disease sites that fall under the umbrella of head and neck cancer. We will identify the different substructures within each disease site and kind of point out some key anatomical structures that you might be asked about either in clinic or on board exams. And then we'll actually divide this talk into two parts. So in part one, we'll focus on the disease sites. And then in part two, we'll come back and talk about principles of lymph node drainage. So we'll talk about the anatomy of different lymph node levels and also general principles of how disease sites drain to various levels of the neck. Let's start by one going through the different disease sites of the head and neck. We're going to go through the individual disease sites in an order that makes the most sense to me, which is from the outside in. So we're going to start with our nose and our mouth, or rather our nasal cavity and sinonasal area and our oral cavity. And then we're going to travel deeper. And so the back of the nose and the back of the mouth are areas that are called the pharynx. So we have our nasopharynx at the back of the nose, oropharynx at the back of the mouth, and then we have our hypopharynx, which is lower and inferior to that. And then we have our throat, which is the larynx. So we're really going to kind of start from the top and we're going to go outside in. So the first disease site we're going to cover is our sinonasal tumors. So you should know that sinonasal tumors are very rare. They only account for about 3% of head and neck cancers. 20 to 30% of these originate in the nasal cavity, and then the rest originate in the sinus. In terms of the anatomy, we have to think about the anatomy of the nasal cavity and then the anatomy of the sinuses. Now, whenever we talk about anatomy in general for head and neck, you always want to keep in mind which structures are included as subsites within that particular disease site. And you also want to kind of keep in mind what are the borders of that disease site. So the anterior and posterior, superior and inferior, and then the lateral borders. So kind of you should be able to draw a box around a disease site and say, okay, anything within this box falls into this particular category. With nasal cavity, it's kind of easy because the structures that are part of the nasal cavity are all the boundaries of the nasal cavity as well. They kind of make up the walls of the nasal cavity. So the floor refers to the bottom of the nasal cavity. The septum is the medial border of the nasal cavity, and then the lateral wall is what contains our turbinates, so the inferior, middle, and superior turbinates. And then there's also an area known as the vestibule, which is the area that's just inside the nostril that kind of is the opening of the nose and the mucosa that's just there. So those are kind of the components of the nasal cavity. And one of the procedures that we frequently do in head and neck clinics is a nasolaryngoscopy. And what we're doing is passing a scope from the outside, so through the nose, and getting into the back of the nose, which is that area called the nasopharynx. And then from there, we angle the scope downward and travel down to the oropharynx. And then we try to get a good look at the throat as well and identify some of the components of the larynx. So as we do that nasolaryngoscopy, the first step is to pass the scope through the nasal cavity to get to the back, which is the nasopharynx. And what we want to do when we do that is to really pass the scope along the floor of the nasal cavity. So we want to be below the inferior turbinate. If you get tangled, more superiorly and you get caught in between some of those turbinates, you might accidentally end up in a sinus. It can be very uncomfortable for the patient. And so we try to stay kind of low and take a straight shot to the back of the nose, which is the nasopharynx. The other component of sinonasal tumor anatomy is the sinuses. And we have 4 sinuses: the maxillary, ethmoid, frontal, and sphenoid sinuses. And I think they're pretty straightforward because the names of these sinuses are kind of closely tied to the names of the bones that they're associated with. So you have your maxillary, ethmoid, frontal, and sphenoid sinuses. The maxillary sinus is the largest, and so that is actually where the majority of sinonasal cancers will originate. Inferior to the nose, the other opening that we have for the head and neck is the oral cavity. And unlike sinonasal tumors, oral cavity tumors are actually fairly common, and you will likely see many of these during your training. So the oral cavity is really everything from the lip, the gums, the hard palate, and then, the anterior 2/3 of the tongue. And so with the oral cavity, there are 7 subsites to know. So those subsites include the lip, the gingiva or the alveolar ridges, the anterior 2/3 of the oral tongue. So remember, the tongue is divided into kind of the oral portion and then the pharyngeal portion. So the front 2/3 of the tongue are part of the oral cavity. And then the base of the tongue, which is the posterior 1/3, is considered part of the oral pharynx. So the oral tongue is the front 2/3 of the tongue, and that is part of the oral cavity. Then we have the floor of the mouth, the buccal mucosa, so the mucosa that's on the inside of your cheeks. We have something called the retromolar trigone, which is kind of the triangular ridge that sits right behind the last molar on either side of your molars, just over the ramus of the mandible. And then finally, we have the hard palate. So if you take your tongue and feel around the inside of your mouth, the oral cavity is basically everything that your tongue can touch. So your lip, your gingiva, also called alveolar ridges, the oral tongue, the floor of the mouth, the buccal mucosa, the retromolar trigone, and then the hard palate. So remember, oral cavity has 7 subsites. Whenever we have cancers of the head and neck, most of the time they're going to be squamous cell carcinomas because everything in our head and neck is largely lined with squamous epithelium. So they're usually squamous cell carcinomas. And because all of these disease sites are just along mucosal linings, it's actually very tricky to see them on imaging, especially on CT scans. And so that is why the exam in head and neck cancer is so important, because on clinical exam, you can often glean a lot of information that can actually guide in management, including designing your radiation plan. With the oral cavity, it's really important for us to examine both with visual inspection as well as palpation. And it's important to try to get a sense of how large the tumor is, what subsite it's originating from, and then also whether there's involvement of additional subsites. Like, for example, if it's in the tongue, is it extending to the floor of the mouth or to the gingiva? If it's in the hard palate, is it extending to the retromolar trigone? So that is something that you can assess on both visual inspection as well as palpation. And so both of those components are very important for the exam. But bottom line here, oral cavity, very common place for tumors to originate, often associated with things like chewing tobacco. And then the subsites, remember there's 7 subsites, and think about just everything that your tongue can touch, and including the anterior 2/3 of your tongue. Those were our 2 outward facing subsites, right? Sinonasal and then oral cavity. Now we're going to traverse a little bit deeper, and we're going to go to the pharynx and the larynx. So the pharynx basically refers to the back part of the nose and the mouth and the throat. And then the larynx is the area that contains our voice box, and the larynx is classically what we think about as our throat. So we have kind of like the back part of the nose, mouth, and throat, which is the pharynx, and then just anterior to that, inferior to our oral cavity, we have the larynx, which contains our vocal cords. So let's start by talking about the pharynx, which is divided into 3 portions. The nasopharynx sits just behind the nasal cavity. The oropharynx sits just behind the oral cavity. And then the hypopharynx sits behind the larynx. Nasopharyngeal cancers are actually fairly rare in the United States, and they tend to be more common in areas like China and Southeast Asia. Uniquely, nasopharyngeal cancers are often associated with Epstein-Barr virus infection, so EBV infection. And we do test for EBV infection in our patients that have nasopharyngeal cancers. In terms of the anatomy of the nasopharynx, it's important to kind of talk about the boundaries of the nasopharynx, right? And be able to kind of draw that box and say everything within that box counts as this type of cancer. So the anterior boundaries of the nasopharynx are the posterior nares and the posterior margin of the nasal septum. Okay, so basically the back part of the nasal cavity is the anterior boundary of the nasopharynx. Posteriorly, the nasopharynx is bounded by vertebral bodies, so C1 and C2. So the nasopharynx is, you can imagine, very close to our vertebral bodies and therefore very close to also our spinal cord and our brainstem. So C1 and C2 are the posterior boundaries of the nasopharynx. Superiorly, the boundary is the base of the skull, or the basosphenoid. Another term you'll hear for the base of skull is the clivus, which is really the sloping part of the base of the skull, and it's composed of 2 bones, the basosphenoid bone, which is part of the sphenoid, and then part of the occipital bone called the basooccipital bone. Inferiorly, the boundary of the nasopharynx is the soft palate, and as we will see, the soft palate is really the top of the oropharynx. So once we hit the soft palate, we're no longer in the nasopharynx. And then laterally, some of the components of the nasopharynx that make up the lateral walls are the eustachian tubes, the torus tubarius, and then the fossa of Rosenmuller. So the eustachian tubes connect our middle ear to the nasopharynx, and they sort of help to equalize pressure. And then the torus tubarius is this projection of tissue that's just posterior to the eustachian tube, and it kind of helps to protect the opening to the eustachian tube. So in the axial image that I have on this slide, you can see a picture of a CT scan, and you can see the opening to the eustachian tubes. You can see the torus tubarius kind of projecting out towards the kind of middle of the nasopharynx. And then just posterior to the torus tubarius, we have this area called the fossa of Rosenmuller, which is also known as a posterior pharyngeal recess. And fun fact, the most common site for nasopharyngeal carcinomas to originate is actually from the fossa of Rosenmuller. So the eustachian tube, torus tubarius, and fossa of Rosenmuller, I would say, are some of the most high-yield anatomical structures that are often asked about in things like mock oral boards, test questions, so on. But what you should know about the nasopharynx is that it sits just behind the nasal cavity. It sits just above the oropharynx, and it's located very, very close to some critical structures, including our brainstem and our spinal cord, and the base of the skull, which contains a lot of very important neural foramina that or I should say cranial foramina, where some very critical nerves kind of come from. And so whenever we have a patient with a nasopharyngeal cancer, we always want to be aware that these cancers can easily involve the base of the skull, they can involve important cranial nerves, and they can actually lead to cranial nerve deficits. And so whenever we're examining our patients with nasopharyngeal cancer, in addition to the head and neck exam and the nasolaryngoscopy, we want to make sure to do a thorough cranial nerve exam and make sure that we don't have any deficits of those cranial nerves. That was the back of the nose. The back of the oral cavity is the oropharynx, which sits just below the nasopharynx. And so remember we said that the soft palate was kind of the boundary between the nasopharynx and the oropharynx. And the soft palate is technically one of the 4 subsites of the oropharynx. Other than the soft palate, the other subsites include the base of the tongue, the palatine tonsils, and then the posterior pharyngeal wall. So the subsites of the oropharynx, remember that there are 4 of them. We have the soft palate, the base of the tongue, the palatine tonsils, and then the posterior pharyngeal wall. And in terms of the boundaries of the oropharynx, the anatomic boundaries are a little bit different than just the subsites. So anteriorly, the boundary is the circumvallate papillae, which are located on the tongue, and they kind of separate the anterior tongue from the posterior tongue. So they separate your oral tongue from the base of the tongue. So the circumvallate papillae, and then the anterior tonsillar pillars, which are, just anterior to our palatine tonsils. So remember, anteriorly, there's circumvallate papillae, and the anterior tonsillar pillars are the anterior boundaries of the oropharynx. Posteriorly, we have the posterior pharyngeal wall. So that's another example of where the structure is the boundary. Superiorly, we have the soft palate. Another example, the structure is the boundary. And then inferiorly, the boundary is the vallecula and the tip of the epiglottis. So the vallecula is kind of this angular shape that is formed between the base of the tongue and the epiglottis, which is the superiormost portion of the larynx. So the epiglottis is part of the larynx, and inferiorly, kind of where the base of the tongue meets the larynx, that is the boundary of the oropharynx. And then laterally, the boundary is the tonsillar fossa and the pillars. So keep in mind that the uvula, so that is that little projection of soft tissue that we see when we open up our mouth and say ah. The uvula is part of the soft palate. And then in terms of vasculature, I think it's important to realize that the tonsils are pretty well lateralized. And so whenever we think about lymph node drainage, if the tumor is just kind of confined to the tonsils, then we can typically get away with just ipsilateral lymph node radiation. So if it's a right-sided tonsillar tumor that's just localized to the tonsils, we can just treat the right neck. However, if the tumor is spreading to any of the central structures like the soft palate or the base of the tongue, these are, vascularized bilaterally, and so they tend to drain bilaterally as well. So even if it looks like it's a very lateral base of tongue tumor or a very lateral soft palate tumor, they can drain to both sides of the neck. And so for those, it's really important to cover both sides of the neck. And so even if you have a tonsillar tumor that's kind of spreading to the base of the tongue or spreading to involve the soft palate, then we still want to cover the neck bilaterally. So far of all the disease sites that we have talked about, some oral cavity tumors, you can get away with ipsilateral nodal coverage. And then the other example of that is really just really well lateralized tonsillar tumors that do not involve the base of tongue or soft palate. We haven't covered the last part of the pharynx yet, which is the hypopharynx. But before we get to the hypopharynx, I think it makes most sense to talk about the larynx anatomy first. So the larynx is our voice box, and it is subdivided into 3 separate parts. So these are the supraglottis, the glottis, and the subglottis. So the most important structure in the supraglottis is probably the epiglottis, and the epiglottis performs a very vital function, which is that whenever we are swallowing, it folds over and it covers our airway, and it prevents food from getting into our airway. So the epiglottis is very, very important to kind of protect the integrity of our airway and protect us from aspiration. So epiglottis is part of the supraglottis. The glottis is very important because it contains our vocal cords. And then inferior to that is the subglottis, which then leads into the trachea. There are 4 main subsites in the supraglottic larynx, and these are the epiglottis, the arytenoids, the aryepiglottic fold, and then the false vocal cords. So the supraglottic larynx extends from the tip of the epiglottis to the laryngeal ventricle. Now, the epiglottis can be divided into the suprahyoid versus the infrahyoid epiglottis. So we know that the hyoid bone is an important bone because that's where many of our tongue muscles have their insertion. Now, there's a suprahyoid epiglottis and an infrahyoid epiglottis, but whenever we're clinically describing where tumors originate from, it's often useful to think about which surface of the epiglottis. So we also have the anterior surface of the epiglottis, which is the lingual surface, and that is where the vallecula is. So that's sort of where our base of the tongue meets the epiglottis. That's why it's called the lingual surface, and that kind of V shape that forms there is where the vallecula is. And then we have our laryngeal surface of the epiglottis, which is the surface that kind of closes over our airway to block food from going in when we swallow. We have our false vocal cords, we have these arytenoid cartilages, and then we also have the aryepiglottic fold. It's important to realize that the false vocal cords are part of the supraglottic larynx, and then the true vocal cords are part of the glottic larynx. So false vocal cords do belong to the supraglottic larynx. And this area called the laryngeal ventricle is, as you can see kind of in the coronal section that we're looking at of the larynx, the laryngeal ventricle is this slit-like opening that lies between the true vocal cord and the false vocal cord. So that's why we say the supraglottic larynx extends from the tip of the epiglottis to the laryngeal ventricle. So that ends up including the false vocal cords, but then the true vocal cords are part of the glottic larynx. Other than the true vocal cords, the only other subsites within the glottic larynx are the anterior commissure and the posterior commissure, which basically correspond to the anterior and posterior walls of the glottis. The anterior commissure you can differentiate from the posterior commissure because the vocal cords kind of form a V shape, and where they join, you can see that is where the anterior commissure is. So think of them kind of like pointing and creating an arrowhead towards the anterior commissure. Now, when we're thinking about radiation for head and neck cancers, we typically treat the area of tumor that's involved, and we also include a pretty large elective nodal field. Most of the time, we're including bilateral elective nodes, and we're treating a pretty significant area within the neck, covering bilateral elective nodal regions. There are select disease sites, as we've already kind of mentioned, where we can consider ipsilateral neck coverage. So that includes well-lateralized tonsillar tumors that are not spreading to the soft palate or the base of the tongue. And it can also include select oral cavity cancers that are very well lateralized and don't have a very deep depth of invasion. So select cases we can consider ipsilateral neck coverage, but the vast majority of the time we're covering the bilateral neck, and that does end up being a pretty large field. The glottic larynx is an exception because unlike most other disease sites within the head and neck, the true vocal cords really don't have as rich of a lymphovascular supply. And so as a result, tumors that are just confined to the true vocal cords have a very low risk of lymph node drainage. And if they're early stage enough, that risk can be in the single digits, less than 5%. And so for tumors that are usually T1 to T2 node negative tumors of the glottic larynx specifically, we can get away with treating just the larynx and omitting all the elective lymph nodes. So we'll talk about more details of that within our kind of subsite lectures when we go through the data and things like that. But just for now, the only takeaway here is that everything in the head and neck has a very rich lymphovascular supply, and so there's a pretty significant risk of lymph node metastasis, and that's why most of the time in head and neck cancers, we're going to have a pretty involved kind of elective lymph node coverage. However, for tumors that are early stage within the glottic larynx, so think T1 to T2 N0 glottic larynx cancers, we can get away with just irradiating the larynx and omitting all those regional lymph nodes. The subglottic larynx then is the area that is inferior to the glottic larynx, and it extends from the inferior surface of the true vocal cords to the inferior surface of the cricoid cartilage. And what's important to keep in mind is that early stage tumors that are confined to the vocal cords, sure, these don't have to be treated with elective nodal irradiation. We can just treat the larynx because they have a low risk of lymph node metastasis. However, if these tumors, even involving the glottic larynx, if they are more advanced, if they're more locoregionally advanced, and if they are spreading towards the supraglottic larynx or towards the subglottic larynx, then the supraglottic and the subglottic larynx do have a very rich lymphovascular supply. And so then the tumors do become high risk of lymph node metastasis. And so as a result, we do need to pursue elective lymph node coverage. And as we'll talk about a little bit later in this talk, depending on which sites the cancer is involving. So for example, if it's involving the subglottic larynx, there are some special considerations in terms of which specific lymph nodes the cancer could drain to. So the subglottic larynx is one of the unique sites that drains to what are known as the level 6 lymph nodes. And the level 6 lymph nodes include kind of anterior cervical nodes, so pretracheal, paratracheal, prelaryngeal, also known as the Delphian nodes, and kind of the perithyroid nodes. So kind of the nodes that are sitting anteriorly to the larynx. So not a lot of tumors drain there, but if it's involving the subglottic larynx, then we do need to think about level 6 lymph node coverage. The other anatomical point that I'll draw your attention to on this slide are some of the important landmarks within the larynx. So we have the hyoid bone, as we talked about, which is the most superior landmark, and you can see that on this slide. And we talked about how the epiglottis that belongs to the supraglottic larynx can be divided into the suprahyoid versus the infrahyoid epiglottis. We have our thyroid cartilage, and around the thyroid cartilage is our actual thyroid gland. So oftentimes whenever we're radiating the head and neck, we have to monitor these patients in the long-term setting for thyroid function, because when we radiate the thyroid, these patients are at risk of long-term hypothyroidism. So we do need to check their TSH and see if they have hypothyroidism. Inferior to the thyroid cartilage, then, we also have the cricoid cartilage, and the cricoid cartilage kind of sits around the subglottis. So these are just important anatomical landmarks to be aware of. So we went through the larynx. Let's jump back to finish out the anatomy of the pharynx by talking about the hypopharynx. So remember, we talked about nasopharynx and oropharynx, which are more superior. And then inferiorly, below the oropharynx, we have the larynx anteriorly, and then we have the hypopharynx posteriorly. And within the hypopharynx, there are 3 subsites, and these are easy to remember with the mnemonic 3 Ps. So the 3 Ps that make up the hypopharynx are the piriform sinus, the postcricoid space, and the posterior pharyngeal wall. So posterior pharyngeal wall is easy to think about because that is just an extension of the posterior pharyngeal wall that was part of the oropharynx. So if it's in the area that's behind the oral cavity, then that posterior pharyngeal wall is part of the oropharynx. But if it's behind the larynx, then that posterior pharyngeal wall is part of the hypopharynx. The postcricoid space is that space that's kind of posterior to the cricoid cartilage. And then finally, we have the piriform sinus, which is this small recess that is on either side of the laryngeal inlet. And whenever we are examining patients with nasolaryngoscopy, we can ask them to kind of puff out their cheeks, and that helps us to see their piriform sinus a little bit better. In terms of the boundaries of the hypopharynx, so anteriorly, it's going to be the posterior cricoretinoid muscle. Posteriorly, it's the posterior wall. Superiorly, it's the hyoid bone. So anything above the hyoid bone is considered oropharynx, and then inferior to that, it's considered hypopharynx. And then inferiorly, the boundary for the hypopharynx is the cricoid cartilage. The cricoid cartilage is a really important landmark. It helps us separate lymph node levels, and it also kind of demarcates the beginning of the trachea as well as the esophagus. So remember, the larynx is surrounded by the cricoid cartilage in that subglottic area. And inferior to the cricoid cartilage, we are no longer in the larynx, but rather in the trachea. The hypopharynx is the part of the pharynx that sits just posterior to the larynx, and we can also use the hypopharynx, or we can also use the cricoid rather as an important landmark for the hypopharynx, because if you're looking at the space that's posterior to the larynx, superior to the cricoid cartilage, we're in the hypopharynx, but then inferior to the cricoid cartilage, we're actually in the esophagus. So when we're thinking about contouring the esophagus, say, even as an organ at risk, the esophageal contour typically starts inferior to the cricoid cartilage. So cricoid cartilage is a very important landmark that sort of represents the very bottom of these head and neck disease sites. I want to briefly review some of this anatomy that we've gone over regarding the larynx in terms of what it looks like on fiber optic laryngoscopy. So remember, one of the procedures that we frequently do in head and neck clinic is a fiber optic nasal laryngoscopy, where we pass a scope, and it has a camera on the end, and we pass that camera through the nose. So we go usually along the floor of the nasal cavity. We get to the nasopharynx, and then in the nasopharynx, we can kind of look around and visualize the eustachian tubes. You might point out the torus tuberous and realize that the fossa of Rosenmuller sits right behind the torus tuberous. And then we kind of angle our camera downward and we move inferiorly into the oropharynx. And there we can observe kind of the palatine tonsils. We can look at the base of the tongue. And then our camera is kind of sitting in the oropharynx and looking down at the larynx. And some of this anatomy is very important to be familiar with. Now, what I just described, going through the nasal cavity and then, looking at the larynx in clinic, is really an indirect laryngoscopy. And whenever we look at indirect laryngoscopy, an example of that is what you see on the right side of the screen. And whenever we're indirectly looking, so we're standing in front of the patient and we're passing the scope from their nose and we're looking down, anteriorly is going to be the epiglottis, because the epiglottis is the anterior facing structure. And the epiglottis to us is going to look like it's at the bottom of the screen. So whatever is anterior is going to be at the bottom of the screen. Whatever is posterior is going to be at the top of the screen. And that, what I just described and what we do in our rad-onc clinics, is an indirect laryngoscopy. In the operating room, our ENT colleagues are often going to be doing direct laryngoscopies, where the patient is, in the operating room and they're, kind of they're sedated, and then the ENT doctors are able to pass, they actually stand behind the head of the patient and pass the scope through. And when they're looking at a direct laryngoscopy, what is anterior in the body, so the epiglottis, is actually going to be at the top of the screen. And what is posterior in the body, so the hypopharynx, is actually going to be at the back of the screen. And so on the direct laryngoscopy, let's briefly kind of just go through and point out some of this anatomy. Anteriorly at the top of the screen on direct laryngoscopy, we see the epiglottis. We see the left and right vocal cords, and this is a really good view, so you can actually see a little bit of the subglottis that's kind of underneath those vocal cords, like inferior to those vocal cords. You can sort of see the left ventricle and the right ventricle. You can see the left and right arytenoid cartilages. And then you also can see some parts of the hypopharynx. You can see the bilateral piriform sinuses, and you can see the posterior pharyngeal wall of the hypopharynx. So that's a pretty good view of a direct laryngoscopy. On the indirect laryngoscopy, you can tell that this is an indirect laryngoscopy because the epiglottis is now at the bottom of the screen. And remember, we said the anterior commissure is kind of formed by the V shape of the true vocal cords meeting, and it's almost like an arrowhead towards the anterior part. So that arrowhead is pointing down, and so you can tell that this is an indirect laryngoscopy. So whenever you do this procedure in clinic with attendings, they'll probably quiz you on some anatomy, and pictures like this can show up on exams. So it's just important to kind of familiarize yourself with the anatomy of the larynx. The other place that anatomy is very important to recognize is on CT scan, because most of the time our contours are going to be performed on a CT scan. And so there are some important landmarks of the larynx that I would just like to kind of point out to you and just to show you how to identify them on a CT scan, because as we will see in our lymph node anatomy, sometimes these landmarks are also used to demarcate different levels of the lymph nodes in the head and neck. So the hyoid bone is, shown on the left-sided picture. And remember, that is kind of in the superior aspect of the larynx. It's where our tongue muscles insert. So the hyoid bone is pretty easy to identify. And, it's a bony structure. So it's going to be quite hyper dense on a CT scan. So it's going to look very white on a CT scan because it's bone. Inferior to the hyoid bone, we have the thyroid cartilage, and the hyoid bone is typically very curved looking. The thyroid cartilage looks more like a point. So and you can tell that it's cartilage, not bone, because while it is hyper dense, it's definitely not quite as bright compared to the bone. So cartilage is still hyper dense compared to most of our soft tissue, but it's not quite as bright as the bone on a CT scan. So the thyroid cartilage is, you can also tell the difference between the hyoid bone because first of all, it's inferior to the hyoid bone. And second of all, the hyoid bone is more of a curved shape and the thyroid cartilage forms more of a pointed shape. And then kind of on the outside of the thyroid cartilage, so anterior and lateral to the thyroid cartilage, you can often see the thyroid gland itself. So that is the hyoid bone and the thyroid cartilage. The other two important landmarks of the larynx are the arytenoid cartilage and the cricoid cartilage. So the arytenoid cartilage sits kind of posterior to the thyroid cartilage, and it doesn't fully form a ring. Remember we saw in the fiber optic laryngoscopy, the arytenoid cartilage is basically like a little nubbin in the posterior aspect of the larynx. And so the thyroid cartilage is kind of framing the larynx kind of anteriorly and laterally. And then the arytenoid cartilage is really just along the posterior part of the larynx. And so you can see the arytenoid cartilage on this scan here, and it's in the same plane as the thyroid cartilage. And then inferior to the thyroid and arytenoid cartilage, what we have is the cricoid cartilage, which forms a complete ring around the larynx. And the cricoid cartilage is a very important landmark, as we said, because inferior to the cricoid cartilage, we have both our trachea as well as our esophagus, which sits posterior to the trachea. So I think this is a good place to wrap up part 1 of our head and neck cancer anatomy overview. In part 1, we reviewed all of the different disease sites within the head and neck and talked about some important substructures within each disease site and various landmarks that can be useful as we're examining patients and also as we're looking at CT scans. So we reviewed sinonasal, oral cavity, and then we also reviewed the pharynx. So that's divided into the nasopharynx, oropharynx, and hypopharynx. And then we also talked about the larynx, which is divided into supraglottic, glottic, and subglottic larynx. So these are a lot of disease sites. And of course, each disease site has different subsites within it. And each disease site within head and neck has subtle nuances in terms of how it is staged and also how it is managed. And so I think before we get into kind of site-specific lectures on the management of head and neck cancers, it's really important to just get a general overview of the anatomy, how we even go about dividing these subsites, and then like I said, this is a beast of a topic, and that's why I feel so intimidated going into a kind of a head and neck cancer series, because there's just so much to cover. But I did want to spend a good amount of time going over some basic anatomical points, because I think that is really important for a foundation before we get into kind of the management details of head and neck. So hopefully this talk has been helpful in understanding, these different sites and the different structures that are included within each site. In our next talk, we will focus on the second half of the anatomy, which is understanding the different lymph node levels within the head and neck, and also discussing some of the principles of drainage. I hope that this anatomy review has been helpful. Thank you so much for your time and attention.